This video we're going to talk about macrocytic anemias. We've already covered microcytic anemias, but now it's time for macrocytic anemias. In macrocytic anemias, we have already discussed before in the anemia overview videos that the MCV is greater than 80. So it means that the cells are going to be big. Now I'm going to tell you how exactly the cells are big. Now we do that, but first the causes. What is macrocytic anemias? It's megaloblastic anemia in which cell size are big, but RBC count is low and HB count is low, and it is due to the vitamin B12 and folate deficiencies. Now, why the cell size is different? Now the cell size is different. I've already written it down for you guys, but I'm just going to draw it out. What happens in erythropoiesis is that first our cells, whenever actually a cell divides, that we have a cell, inside the cell we have the DNA, and the outside the cell it's the cytoplasm and all that, right? So in nucleus we have DNA and cytoplasm, we have RNA and proteins. Now the thing to know that with folate and vitamin B12 deficiency, what really is getting compromised is the production of TTP, that is thymidine. So it is important to know that thymidine is important for DNA, but not for RNA. RNA do not have a T. Instead of thymine, it has uracil. So RNA is not going to be affected, but DNA is going to be affected. So that concept is important. Now, when you have this concept that only thymidine is getting, there's a problem with the production of that. So DNA, we do not have enough DNA. DNA is less, so nucleus is going to be small, right? So we're going to have a small nucleus because we don't have enough DNA to replicate. But we're going to have everything else. We're going to have all the other protein precursors, and we're going to have all the other RNA precursors. So the cell cytoplasm, it is going to increase. So that is why these cells they're big cells, but with small nuclei, right? Now, this megaloblastic change in, association with the red blood cells is also seen in the epithelial cells, that are intestinal cells that are rapidly dividing. Also, because thymidine is also important for the production of granulocytes that are going to make your WBCs, that is also going to be impaired, and they are going to be hypersegmented, which I've already covered these 3 facts in a previous anemia overview video. So now we know why it's megaloblastic anemia. So now we're gonna move on towards the the process in which folate and vitamin B12 are kind of interlinked, and how does it happen. So really the important thing that we need in a DNA synthesis, that I'm also going to cover in biochemistry lecture of pyrimidine and purine synthesis, that is methyl tetrahydrofolate. So methyl tetrahydrofolate is basically, it assists the enzymes in the synthesis pathway. Methyl tetrahydrofolate is going to get converted into tetrahydrofolate, and this tetrahydrofolate is going to cause the synthesis of DNA precursors like TTP and etc. But the methyl of tetrahydrofolate is transferred to cobalamin, that is vitamin B12. And this vitamin B12, after its function, it is going to send this methyl group to homeocysteine, and then this homeocysteine is going to become methionine. It is important. This association is important. It is going to come up later in folate deficiency. I'm going to explain it to you there as well. Now we're going to move onward towards the folate deficiency first. So folate is basically a form of vitamin B, and you get folate from green vegetables, right? So the sources of folate are green vegetables. Are green vegetables, plus you can get it from some fruits as well, right? and it is absorbed in the jejunum. So absorption of folate is in jejunum. So these are just some random facts that you need to memorize. Now, important thing is that, like iron, folate is also stored. So that is why folate deficiency is going to develop within months. It is going to take time to develop. And its causes, now when we talk about causes, we have our poor diet, and mostly poor diet. With it, we're going to have alcoholics. We can have elderly people, right? Also, if there is any kind of increased demand, like in pregnancy, right? Or in cancer, or in hemolytic anemia, right? In hemolytic anemia, in which, RBCs are being attacked, and those are the hemolytic anemias. Or if you're giving methotrexate. Methotrexate is a drug that inhibits dihydrofolate reductase, DHFR, and it's actually an anti-cancer drug, or a cytotoxic drug. Then we have, what are the lab findings of folate deficiency? Now, it is going to be macrocytic. So labs are going to be macrocytic anemia, macrocytic RBCs, and they're also going to be hyper segmented neutrophils, right? And there's going to be glossitis. A glossitis is enlargement of tongue. Because it is not due to anemia, it is due to the folate deficiency that is also causing your tongue to enlarge. It is going to be red, beefy tongue. Of course, your serum folate is going to be low, so low folate in serum. And your homeocysteine is going to be increased. So serum homeocysteine will be increased. So right here above, I've told you why it was important, is that if you don't have hydrofolate, you don't have folate, you won't have methyl tetrahydrofolate. So essentially you cannot give methyl to cobalamin, and that is not going to convert homeocysteine into methionine. So it is going to have increased homeocysteine, right? And increased homeocysteine is going to then increase your risk of getting thrombosis. And finally, yes, and that's it for the folate deficiency. Next, we're going to do vitamin B12 deficiency and how it causes megaloblastic anemia. So in vitamin B12 metabolism, first we need to know what goes on. So this is the overview, what happens, right? And I'm gonna zoom in. So vitamin B12 is coming from the sources. So any food source, we're gonna have vitamin B12. And in the mouth, we have salivary glands. This salivary glands release heptocorin. This heptocorin it's actually an R binder. It will bind, so it is actually an R binder, or heptocorin, and it's going to bind with vitamin B12 and form a complex, right? And then this is going to travel straight through the stomach, straight through the intestine. It will enter the intestine lumen. In the intestine lumen, we have pancreatic enzymes released from the pancreas. These pancreatic enzymes is going to unbind or break the bond between B12 and heptocorin. And from the stomach, now this is important, this intrinsic factor is produced from the stomach. And it is now going to bind with B12. So again, it is in the stomach. B12 is still going to be bound to heptocorin. It is not going to bind with intrinsic factor, but intrinsic factor is produced in the stomach, and it is only bound in the intestine when pancreatic enzyme is going to break the bonds between B12 and haptocorin. Now we have B12 and IF, intrinsic factor. Now it is now going to enter the enterocytes, and from the enterocytes it's going to enter the plasma, and from the plasma it is then going to get distributed in the liver. It could be then stored in the liver, and when it's required, it is released into plasma, and if it wants to get excreted, it will be excreted into the kidney, right? So this is the whole scenario about vitamin B12 regulation, storage, absorption, etc., etc. And now vitamin B12 deficiency can occur, but it's less common than folate deficiency because it can take years to develop, because there are large hepatic stores of vitamin B12. In liver, vitamin B12 is highly stored. But important thing is that even though you have enough vitamin B12, but there is a condition called as pernicious anemia. So pernicious anemia is actually autoimmune disease. It is an autoimmune disease. It is called anemia, but bear with me, listen to it. It's an autoimmune disease that is going to affect the cells, the extrinsic cells that form intrinsic factor. So actually in pernicious anemia, there is no intrinsic factor. Even though you have ample amount of B12, but you don't have intrinsic factors, they won't bind. And this pernicious anemia is then going to cause a vitamin B12 deficiency, and that is going to cause megaloblastic anemia. That's that. So, then we have, okay, these are the parietal cells, not exentic. I'm very sorry of my slip of tongue. These are parietal cells. All right. Then we have other causes. This is one of the causes of vitamin B12. Other causes, there could be pancreatic insufficiency, right? And there could be damage to terminal ileum, right? It could be Crohn's disease. It could be tapeworms. So there are, other examples. Like I'll list it down anyways. Examples, it could be pancreatic insufficiency. Why pancreatic insufficiency? You see in above scene that pancreas is producing an enzyme that is unbinding B12 and haptocorin. So if you don't have enzymes or there is pancreatic insufficiency, this is not going to be broken down. Then how are we going to absorb vitamin B12, right? So that makes sense. And again, another is the terminal ileum destruction, right? Any kind of damage. It could be Crohn's. It could be tapeworms, right? Again, if you have a damaged intestine, how are you going to absorb it, right? How are you going to absorb it? Okay. Then we have certain labs. Labs are going to show, two of the same things. It is going to show macrocytic macrocytic RBCs, the same as folate. Plus hypersegmented neutrophils. We all know the reason to this, right? I've already told you, because of the DNA precursors. Then we have glossitis, again due to vitamin B12 and folate deficiency. Both have the glossitis. And then also subacute combined degeneration of spinal cord. This happens because of vitamin B12 is actually, myelination will not occur. Now, this is happening because of damaged or impaired myelination of the neurons of the spinal cord. And this is the reason to this is, now this is because in fatty acid oxidation or fatty acid metabolism, beta oxidation, we have vitamin B12 is a cofactor. It is actually cofactor for the enzyme that is going to convert methyl malonic acid to succinyl CoA. So if this is going to help the enzyme that does this, when it's deficient, it won't happen, and the right fatty acids are not produced, so myelination is not going to happen, because we know myelination is insulation, that's fat, right? So the damage is going to cause all the problems. Is poor proprioception, and also paresis, and also the vibratory sense is going to be impaired. So these are the things that are impaired, right? Now, other labs is going to include decrease in serum B12, and increase in homocysteine. I've already told you how that happens. And also methyl malonic acid, MMA, is going to increase, but it is not going to increase in folate, not increased in folate deficiency, because they're not related, right? They don't have anything in common. So that's that. So it's important to study both of these anemias together. It's very easy, and that is it. Thank you so much.